All right, guys. Now we're going to cover Chapter 23, Part 2. We're going to start out on page 909 with diagnostic testing. All right. So we know diagnostic testing that may be appropriate for some patients with respiratory illnesses, such as our pulse oximetry or capnography, and the use of peak flow meters. Now, peak flow meters we are going to talk about because they are utilized at the National Registry level. However, we don't see them utilized that much in this area. Pulse oximeters measure oxygen saturations. CO2 monitors or end-tidal CO2s measure our CO2 levels as we're exhaling. And our peak flow meters provide a baseline assessment of the airflow for a patient with obstructive diseases. So a lot of times your patients have these at home, or they might be on an ambulance, and what they do is test the actual resistance when a patient exhales. So the first we are going to talk about is pulse oximetry. I think we all have a good understanding of what a pulse oximetry is. It determines how well the patient is being oxygenated. Remember, I told you look at your pulse oxes for oxygenation and look at your end-tidals for ventilation. This device measures the transmission of red and near-infrared light through arterial beds, such as in our fingers, our toes, and our earlobes. You'll see some that get placed on the foreheads and all. As long as that particular device is utilized for that area, you'll get accurate readings. However, if it's not technically designed for that area, you might not get that accurate reading. We know that hemoglobin is that is bound with oxygen. It's what we call oxyhemoglobin, and it absorbs more infrared light than red light. So what this machine does is it goes in there and it looks at the reduced hemoglobin absorbed more by the infrared light compared to what is absorbed by just the red light. The pulse oximetry measures that difference and calculates your SaO2 level. The low ranges of normal, SaO2 93 to 95% is what we consider low normal, or low. Your upper ranges of normal is 99 to 100%. Any SaO2 reading below 90% equates to about a PaO2, which is what we call a partial pressure and arterial oxygen level of about 60 millimeters of mercury, and that's going back to an ABG test there. And then if you've got one where SaO2 or SpO2 readings of 75%, that indicates a PaO2 level of about 40 millimeters of mercury. And a SaO2 of 50% is equivalent to about 27 millimeters of mercury on a PaO2 level. Capnography. Now, from day one, you know that I'm an advocate for capnography or capnometry, preferably capnography. Now, remember, capnometry is a numeric. Capnography is a graph. And in capnometry, you can have and capnography together, where you have the number and the graph. Capnography is a non-invasive monitoring technique that is used in the pre-hospital setting. In my opinion, not enough. We need to work on that. But what it is to confirm correct ET tube placement. And when it's used in conjunction with a pulse oximetry and ECG monitoring, capnography can also provide an insight into the ventilation aspect of the patient and indirectly to the circulation and metabolism of the patient. It is a useful indicator of efficient cardiopulmonary resuscitation, because remember, when we're doing CPR on an intubated patient, those numbers and those levels that we want to keep that CO2 at. And it can also be useful in determining possible PEs. Now, we can't just say, well, this is the driving force behind diagnosing a PE. Ultimately, a CT scan is, but it kind of just helps us lean towards some possibilities. And patients with hemorrhage, continuous end-tidal capnography is very useful and provides us indirect information about specific tissue perfusions itself. Because think about it, what does end-tidal measure? It measures CO2. Where is CO2 produced at? It's produced in an aerobic state at the cellular level at the tissue sites. And it can also be an indication of fluid resuscitation effectiveness in patients in shock. So like I told you in the shock section, sometimes what I like to do on those, ideal textbook patients that are septic shock, and do I go pressor or do I go fluid first? Which one do I need to do? If they're intubated, again, we're talking about an ideal situation right now. They're intubated. What I'll do is I'll lay them flat, and then I'll do a passive leg raise. That passive leg raise is approximately about 250 cc fluid bolus equivalent. If I see a pretty significant jump in my end tidals when I do that leg raise, then I'll probably give that patient some blood. If I don't see a jump in my end tidal when I do that passive leg raise, then I'm usually pretty quick to go on to do a vasopressor infusion on this patient. Before we get into the peak flow meters, use of capnography in a medical patient with spontaneous respirations is relatively easy to do. A majority of our nasal cannulas come now with the option to have end tidal CO2 monitoring with that nasal cannula. And same concept, how it works, the exact same concept, okay? The measurements are taken by the capnography adapter attached to either a BBM mask, a nasal cannula, or, as we're used to seeing it now, in the intubated patient. The graphic representation is displayed as a waveform measured in millimeters of mercury on the capnograph throughout the respiratory cycle. Remember, like I said, a capnometry displays only a numerical value of an indirect measure of the PaCO2, not the waveform. So anytime you see the capnometer, or where all you're getting is a number, where they say, hey, we're getting capnometry, that's a number. Each waveform on the capnograph consists of 4 phases. You have phase 1, and that's point A to B. And what that represents is that the air that is exhaled from the conducting airway has little to no detectable CO2. And that's air that's usually located in your dead space where no oxygen exchange and CO2 exchange took place. Then you have phase 2, which is from point B to point C. Now, if you look on, we'll go back here. There we go. Sorry. So point A to point B. And let me get my laser pointer here for you. So this is point A to point B right here. That's phase 1. There's little to no CO2 there. So if there's little CO2, you might see a little rise in right here, but most of the time this is flat, and it's also what we refer to as a CO2 baseline. So as the patient starts breathing out, and usually this is kind of that respiratory pause between inhalation and exhalation. So once we get to phase 2, which is right here, and that's where we start this upstroke from point B to point C, and this is where exhalation begins. So we start breathing out, and as we start breathing out, you'll usually see a slight upslur here going into this point here. What that is where we start moving air from the lower airways, where we start actually having gas exchange takes place. And as we're moving up right here, this represents the mixture of air from the atomic dead space and some alveolar gas. That's why we have that increase there. It is here that carbon dioxide concentrations begin to rise. So we start detecting that CO2. Phase 3, which is point C to point D here, that's what we call the plateau. That represents a plateau as alveolar gas is exchanged or exhaled. This peak number right here, or the highest point, usually which is point D, is what we call the end tidal. Then you have phase 4, which is point D to point E. And at this point, this is where the patient stops exhaling and begins to inhale. And this is where oxygen-rich air is passing through the sensor instead of CO2-rich air. And we get back down to the baseline and start it all back over here. Now, we can utilize this waveform, like I said, to look and see, do we have shark fin waveform? And shark fin waveform would be from like point B here to point C, but you don't have that upstroke. You kind of have it more of a, like this right here. All right, remember, this is exhalation phase right here. So if we're exhaling and it's taking a longer amount of time to exhale to get to that point, think bronchoconstriction, right, or airway obstruction in some way. You can also look at rebreathing carbon dioxide. What happens there is associated with that increased dead space, and what starts happening is this right here will pick up some and your baseline will start getting up because we'll never get that CO2 back down to its low, hopefully around the 0 point there. Okay, so it starts picking itself up. Baseline gets higher and higher. It actually starts to look like it's stair stepping up. That's what we call rebreathing. Patients with obstructive lung disease or pulmonary embolism will have that decreased angle in phase 2, like I said right here, and have that shark fin appearance. Also, if you look on page 911, you'll see in figure 23-4, you'll see what they're talking about. The first one is that shark fin, and that's that sign of bronchoconstriction. Your next one, you'll see that prolonged expiratory phase, not necessarily looking like a shark fin. It just kind of goes up and then hits and then draws out, flatten out across. That's what we look at when we start thinking about PE. Again, don't put a lot of emphasis on that. We still need to use other forms of verification on that. Another thing you can look at is you have, say you got an intubated patient and you've got low rolling end-tidal forms, but they're consistent moving through. You know the tube's in place and all that. You can start looking at perfusion problem or low BPs. So sometimes your end-tidals might be telling you that the patient has low BPs, and we're constantly cycling that blood pressure, that non-invasive blood pressure over and over, not getting anything, but yet we got these low amplitude CO2s. That's probably telling you that the patient's got low perfusion status. All right, peak flow meters. Peak flow meters are used in the pulmonary function test to measure the patient's peak expiratory flow rate, also known as the PFR. PFRs is a measurement of how fast a person can exhale air. Remember, in a bunch of your obstructive pulmonary diseases, is problems getting air out. These tests most often are used to help determine the severity of an asthma attack. When I was going through nursing school, they'd actually, they would tell us about doctor clinics and stuff like that. They would tell you, all right, use your peak flow meter, and when it gets to this number right here, that's when you start calling for help. I don't know about all that, but anyway. They can also assess the effectiveness of your treatment. The use of flow meters requires a cooperative patient who can achieve a maximum respiratory effort. In other words, if your patient's having a hard time to breathe, don't give them a peak flow meter and tell them, hey, start breathing in this. I need to see how bad you really are. You're wasting time. Right? So in order to obtain a baseline before drug administration, the paramedic should instruct the patient to inflate the lungs fully. Take a deep breath in, hold it for just a second, place the peak flow meter in their mouth, their tongue under the mouthpiece, and their lips sealed around the top firmly, and then forcefully exhale as quickly as possible. And what will happen is then it will send this little dial up the meter, whether it be a ball or whether it be a actual little gauge, it'll slide up. The reading is recorded in liters per minute. This measurement should be taken 2 to 3 times to get a good baseline. The highest of the 3 readings is chosen as the peak flow value. Of course, these vary with age, race, and sex. A PFR measurement with variability less than 20% is considered mild. If they've got a 20% to 30%, that's considered moderate. And if they have more than 30%, it's considered severe. Peak flow measurements should be repeated throughout the course of management to evaluate the patient during the drug therapy. Now, that's great that you know all that, and yes, it can be useful. But again, don't rely on a piece of equipment to tell you what you already know is wrong with the patient. Okay. All right, obstructive airway disease. Obstructive airway disease is a major health problem, as I would say accounts for a large amount of our call volumes. There's certain, I guess you can say, aspects that obstructive airway diseases can cause cardiac problems, and cardiac problems can cause obstructive airway diseases. And so, therefore, a lot of times it might be obstructive airway disease in nature, but that might not be the reason we get the call. So have to understand the pathophysiology behind some of these disease processes and their affiliations with other disease processes. Some major health problems that are associated with obstructive pulmonary disease is smoking, environmental pollutions, industrial exposures, various pulmonary infection processes. You'll see it a lot with a lot of like your older people that used to smoke the non-filtered cigarettes and stuff like that. Again, not saying filters makes it any better, but you also see it in certain types of industries, like it says there, industrial exposures. So obstructive airway disease is a triad of three pretty much distinct diseases that often coexist together. You have bronchitis and emphysema together. They're referred to as your COPD patients. And then you have your chronic obstructive asthmatic patient. These diseases are presented separately in this chapter, but however, they can present themselves together in patients. So, chronic bronchitis. Chronic bronchitis is a condition involving inflammatory changes and excessive mucus production in the bronchial tree. Chronic bronchitis is characterized by an increased number and size of the mucus-producing glands inside the pulmonary system. This increase results from prolonged exposure to irritants such as smoking, just inhalations, like again going back to that industrial exposures and so on. The condition itself is diagnosed clinically by the presence of a cough with mucus production that is present on most days for at least 3 months, and then is consecutive 2 years, with or without an identifiable cough. The alveoli are not seriously affected, and diffusion remains relatively normal. Patients with severe chronic bronchitis have a low partial pressure of oxygen levels because they change in the ventilation-perfusion relationship in the lungs and hypoventilation. These patients are sometimes what we call the blue bloaters. So I'm sure you've heard this, blue bloaters and pink puffers. All right, so your chronic bronchitis, think bronchitis, blue bloaters because of their hypoxia and their fluid retention. The hypoventilation leads to hypercapnia, meaning they got higher than normal levels of CO2, and hypoxemia, lower than normal levels of oxygen. And they have an increased PCO2 level. So when you put these patients on those end-tidal nasal cannulas, you're going to see higher numbers of CO2s. Patients with chronic bronchitis have frequent respiratory tract infections that can eventually lead to scarring in the lungs. And so just like anything else, once that scar tissue is present, it just makes that organ function more difficult. These changes can lead to emphysema and bronchiostasis. Bronchiostasis is an abnormal dilation of the lungs. It is caused by congenital factors and can be acquired, such as after a purulent infection of the bronchial walls. And again, all that bronchial, like if you look at your key terms up here, bronchiostasis is an abnormal dilation of the bronchial walls. And there's a picture of chronic bronchitis. And again, notice here how the bronchial trees are just full of mucus. And there's your submucosal glands, like you see there. They're full. Also, look over here. You have hyperinflation of the alveoli. Again, this is due to that air coming in. And then because you got to think, air coming in is a forceful thing. We pull that air in. However, when we go to breathe out, it's a passive process, so that air doesn't go under as much pressure getting out. So them lungs stay inflated, and then we take another breath in, and it just inflates them some more. And after so long, those alveoli begin to adjust, and they just stay hyperinflated like that. Emphysema. Emphysema results from pathological changes in the lungs. It is the end stage of a process that progresses slowly for many, many years. The disease is characterized by permanent, abnormal enlargement of the air spaces beyond the terminal bronchioles. It does lead to destruction and collapse of the alveoli. The disease reduces the number of alveoli present and available for gas exchange. It also reduces the elasticity of the remaining alveoli, so we lose that ability to be able to recoil and go back to normal. Because of the loss of elasticity, it leads to trapping of the air in the alveoli. You have residual volume increases, whereas vital capacity remains relatively normal. So go back to chapter 15 where we talked about the residual volumes, your vital capacity, and again, that kind of self-explanatory how that process affects the body there. The association of the reduction in arterial PO2 levels leads to increased production of red blood cells, and that's where we have that caused by an elevated hematocrit level. The elevation in hematocrit levels is much more common in patients with chronic bronchitis than in patients who just has primary emphysema, because the patient with chronic bronchitis is more often chronically hypoxemic. However, decrease in the alveolar membrane surface area and the number of pulmonary capillaries in the lung reduces the area of gas exchange, and this causes an increase in the resistance of pulmonary blood flow. But your redness comes from that large amount of hematocrit inside the body in relation to a normal patient, because the body is producing more oxygen carrying capabilities by increasing more red blood cells, and that's called polycythemia. I had a blank there for a second. So there's your patients that are coming in that we call them your pink puffers. Okay, patients with emphysemas have some resistance to airflow both in and out of the lungs, yet most of the hyperexpansion is caused by air trapping secondary to the loss of the elastic recoil we talked about just a second ago. Patients with chronic bronchitis have increased airway resistance during both inspiration and expiration phase. In contrast, patients with emphysema have increased airway resistance only on expiration. Because remember, chronic bronchitis, that was that mucus plug-in and all that, so we had a hard time getting air around it, just as much as we had a hard time getting air out. Chronic emphysema is a problem with that passive part of exhalation, so we have a harder time getting air out. Normally, a passive involuntary act in expiration becomes a muscular act in these patients, so these patients start getting tired. Again, this is their pink puffers due to that constant pulling air, again with that pursed lip, because we're trying to keep that PEEP up, that pressure, and also due to that polycythemia, they get that red pinkish appearance. Over time, the chest becomes barrel-shaped from the air trapping. They're usually thin and frail because they're constantly working their muscles and they're using up that caloric storage and all that from that. Full deflation of the lungs becomes more and more difficult, and eventually it will just become difficult to impossible. Often the patient with emphysema is thin because of that poor dietary intake, like I just said, and they'll constantly burning through that caloric reserve they have. They have bullae, which is deflated air-filled sacs within the lungs parenchyma. Think parenchyma, just lung tissue itself. And this often develops in patients with emphysema from the destruction of those alveolar walls, where we just start seeping in. We start having these little air pockets pop up in there. Then you'll have blebs. Blebs are air-containing spaces between the lungs and the visceral pleura. They can develop. Now, not much we can tell in the back of an ambulance about versus blebs, so to say. However, what I need you to understand is these open a door for the patient to have spontaneous pneumothoraxes. So these patients are very, very prone to have spontaneous pneumothoraxes if we have a rupture of these blebs and so on. The assessment of a COPD patient. Assessment with COPD usually are aware of and have an adaptus to their illness. However, when we do get this call, it is due to the patient's condition and an acute episode of worsening. Really comes about when they're at rest. That kind of gets them scared. They're used to getting up, moving around, and getting a little short of breath. However, when they're just sitting there watching TV and they start getting short of breath, it makes them nervous. And again, if you think about it, that's the worst thing that can happen, is for them to get nervous. They'll have an increase or change in the sputum production, or an increase in the malaise that accompanies the disease itself. Other common complaints include the inability to sleep and recurrent headaches due to the decrease in O2 levels throughout their body. On EMS arrival, the patient with COPD will likely be in respiratory distress. Again, they're usually used to being in respiratory distress, but if they got to the point where they called you, that means it's gotten worse. Often the patient is sitting upright and leaning forward to aid in the breathing. The patient is frequently using a pursed lip breathing to maintain positive airway pressure. So if the patient's attempting to do that, that should help us here in just a second determine how we're going to treat that patient. If they're trying to maintain their own positive expiratory pressures, why would we not assist them with a tool that we have, i.e. CPAP, BiPAP? The increased hypoxemia and hypercapnia may indicate the patient to be tachypnic, they'll be diaphoretic, cyanotic, they'll have confusion, irritability, and drowsiness. Some other physical findings include wheezing and rhonchi and crackles. Again, we can treat those as we hear those. Breath sounds and heart sounds also can be diminished due to the reduced air exchange and that hyperinflation inside the lungs. The patient may have peripheral cyanosis. They can have closing of the fingers. Again, remember that is a long-term chronic effect. The patient's ECG may reveal cardiac dysrhythmias, or they can show signs of right atrial enlargement, and you'll find that with peak T waves in leads 2, 3, and AVO. And again, this is not stuff that you're like, oh my goodness, they got peak P waves. P waves. They got atrial enlargement. Yes, that is a sign of atrial enlargement. It's a pretty prominent sign, but that's not going to say, well, they ain't got that, so it's not COPD problem. Again, these are just some other side note clinical findings you can have. All right, the management of a patient with COPD. So the management, the primary goal for pre-hospital care for these patients is to correct the hypoxemia through improved airflow. Airflow can be improved through the administration of oxygen by changing the partial pressure, just putting them on oxygen. NIPPV, your non-invasive positive pressure ventilation, such as CPAP or BPAP, and then drug therapy as needed. Drug therapy can cause some serious side effects and complications with these patients, so be careful. I'm not telling you not to use them, just be careful, okay? Especially in the patient that has used these medications prior to EMS arrival. So we should also take into consideration what that patient has done to help themselves prior to our arrival. That goes into obtaining that thorough medical history. You want to get an IV pretty quick. Obviously, it's going to place the patient on cardiac monitor, all your other diagnostic equipment, end-tidals, SpO2s, and so on. Ask the patient if they have a productive cough. If they're able to cough, and it sounds like they got to cough something up, urge them to cough and try to clear their own airway of that phlegm and mucus. Any sputum should be collected and transported so that it can be utilized for laboratory cultures and analysis and so on. And it also gives you an idea, because you can kind of look at it, like I said in previous video, on looking at it. Is it blood tinged? Is it blood streaked? Is it that rust color like with pneumonia, or so on? Some patients with COPD rely on their hypoxic drive for ventilatory efforts, and we discussed this in class the other day. However, as a paramedic, we should never withhold oxygen because of the fear of decreasing the hypoxic drive in a patient in the pre-hospital setting. Oxygen should be titrated on that patient's particular oxygen level, and usually once you start turning around a little bit, they can tell you what's normal for them. Some of these patients will require ventilatory assistance. In addition, their breathing may require augmentations of a CPAP or a BPAP. Again, don't be afraid to use CPAP and BPAP on these patients. Okay. Obviously, if you have BPAP, that's better than CPAP, but utilize CPAP if that's all you got. Both methods can improve oxygenation. It can reduce the workload of the heart. It can reduce the workload of the lungs. It can reduce the workload of just breathing in general, which then brings the anxiety down on that patient. Now, the drawback to that is they're going to be slightly anxious when you first put it on them. So you might have to do some coaching and hopefully not get to the extent of using pharmacological means to help with that anxiety, but you do have that medication for angiolisis when it comes to providing CPAP. But remember, in order to do CPAP, that patient has to be conscious and able to follow commands. NIPPV, may prevent the need for intubation. One of the worst things we want to do with a patient with COPD, asthma, and so on is intubate them. Just increases their likelihood of not coming off the ventilator and makes it even harder for them to recover. Okay. Some medications that you might use in the pre-hospital settings are used to really reduce the bronchoconstrictions. That's your beta agonist, aka your beta 2 agonist. That's your levobuterol, your albuterol. You can actually have a nebulized anticholinergic. That's the one that we talk about giving in association with your beta 2 agonist albuterol, and that's like your ipratropium bromide. Remember, though, they're not the same medication. One is a beta 2 agonist and one is an anticholinergic. And what their promotion is often administered, like it says, with that beta agonist to promote bronchodilation, and it also inhibits the further production of that mucus. Some cases and some transport environments, you can administer the steroids. I do know that there's a couple in our local areas that do administer steroids, such as Solumedrol or Decadron or something along those lines. If you had to choose, I would say go with Solumedrol, and it just helps with the inflammatory process, which also helps with the decrease in the mucus production. All right, so we're going to stop it right here for right now, and we'll do a part 3, and that's where we just take each disease of COPD or obstructive airway, restrictive airway, and kind of talk about them specifically. All right, got any questions? Follow up with me.